Welcomes attendees and physicians for Latin America, Middle East, and United States. My name is Vicente Orozco. I'm a cardiothoracic surgeon and assistant professor of surgery at Baylor College of Medicine. As a part of our mission to promote the medical knowledge through educational programs, the International Center at Baylor St. Luke's in Houston, Texas, in collaboration with Baylor College of Medicine and the Texas Heart Institute, we are honored to host the 14th International Virtual Roundtable to our network of physicians, medical societies, and international medical community. Our today's topics, it will be on complex aortic surgery, a heart team approach. Allow me to explain the format for today's program. First, we will open with a presentation for Dr. Guillermo Silva. After his presentations, we will have Dr. Coselli lecture on complex aortic disease. Please feel free to submit questions via the chat box located in the bottom of your right screen. In post-presentations, we will open virtual roundtable with questions, comments, and observations from our speakers and for the audience. Para las personas que hablan español, por favor, manden sus preguntas en español y yo me encargaré de traducirlas y pasarlas a los respectivos ponentes. Primeramente, empecemos dándole la bienvenida al doctor Guillermo Silva. Let's start by welcoming Dr. Guillermo Silva. Guillermo Silva is the Director of Structural Heart Disease at Baylor College of Medicine at the Texas Heart Institute. He's an assistant professor at the Baylor College of Medicine. Dr. Silva is a board certified in cardiovascular disease, interventional cardiology, internal medicine, nuclear cardiology, and echocardiography. Dr. Silva is an expert in complex interventional cardiology procedures, including from percutaneous transluminal coronary angioplasty or stenting. And also he has a special training in structural heart disease interventions and performs procedures such as transcatheter aortic valve replacement, TAVRs, and mitral clips. Lastly, he offers all kind of structural valve interventions. Welcome, Dr. Silva, and we're looking forward to your presentation.
Well, thank you very much, Vicente. Thank you for the invite, and it's a pleasure to be here. You guys can see my screen, correct? Okay. So we're doing today, the theme is aortic valve surgery. And there's a lot that the surgeons can do. And I think one of the most important things that we've seen lately in the past 10 years in cardiology, it has been the collaboration between the surgeon and the interventional cardiologist. It's been extremely successful collaboration since the Syntax trial. And you see here that not only in the TAVR world, but also in the coronary artery disease world, we are actually expanding this collaboration of the heart team. And especially because this is very special because it becomes a more patient-centric approach instead of a, if it comes to me, I do TAVR or I do a stent, or if it goes to a Dr. Orozco or Dr. Coselli, they go ahead and do a bypass. No, it's the best for the patient. So I like to start with a little bit of a case, and so that we can set up our discussion with Dr. Coselli. So this is a 67-year-old woman with a past medical history of hypertension, diabetes, coronary disease, had remote PCI, and had an aortic dissection, a status post repair in 1983. And this case was done about 6 months ago and had cystic medial necrosis. So this is a patient that presented about 6 months ago. So she presented with acute onset shortness of breath and chest pain, was hypoxemic in an ER outside, was intubated after CPAP trial failed. And essentially she was diuresed, and that CTA of the chest in an outside hospital showed an acute type A aortic dissection. So we have somebody that has a history of aortic valve disease that comes in cardiogenic shock or in hypoxemic and pulmonary edema, and was started on norepinephrine, and a bedside echo outside showed biventricular failure and wide open aortic regurgitation. So when the patient presented to our hospital, she was transferred under Dr. Coselli's team, And one of the first things that Dr. Coselli's team asked us to do was to perform a transesophageal echo to see what was this, why was this patient in shock and why was this patient having so many issues. And we do have a very strong imaging core group represented by Dr. Conero mainly, which is our advanced imaging specialist. And you see here in this image that this is a big aorta, an aneurysmatic aorta, that essentially the aortic valve is non-coapting. And once you put the Doppler here, you see that the diastolic flow, there's torrential aortic regurgitation that is probably acute and represents what the patient has, which is causes the cause of the cardiogenic shock. So this patient was not doing well at all, was on multiple pressors, urinary, the urine output has decreased. So we do have also another member of our team, which is Dr. Simpson, who is a specialist in mechanical support. So we discussed this, Dr. Coselli, myself, Dr. Roscoe, and Dr. Simpson, and we decided that the best support for this patient was not a balloon pump, was probably something more, maybe ECMO, or in this case, we could not use an impella given the dissection. So we thought the safest route for this patient was to have a tandem heart placed in. So to your left in the screen, you see what looks like more of a big, almost like a football in the patient's chest, which is this huge aneurysm. And the pigtail catheter here is opacifying. And you can see here that the coronaries, the right coronary and the left coronary, are well patent and open, kind of ruling out the coronary issue or coronary event as a cause for cardiogenic shock. And here you can see the pigtail, and here the intracardiac echo catheter. And you see that Dr. Simpson has gone transeptal into the left atrium and placed the tandem heart into this patient. So here is the CT, the 3D reconstruction of this patient. You see here, this is a cannula of the tandem heart catheter going through the interatrial septum. You see here the cannula going into the left femoral artery. And here is the aneurysm. Just to look at this and to kind of show the complexity of this patient. There's a graft here with like two 90-degree curves. This is not a easy surgery. I think that this would be probably hours of these deep circle arrests, and we'll discuss this a little bit more, and Dr. Coselli can comment this one on his presentation. So we had a lot of discussions around this patient. Patient in the 60s, fully functional, was completely with it, was in cardiogenic shock with biventricular failure and wide open AI. Now what? What should we do? And apparently the mortality of this patient on a tandem heart was probably, with open heart surgery, was probably, I would say at least 80%. So this is the old model, right? Which is the cardiothoracic surgeon looks at it, assesses the risk, assesses the severity, indicates the procedure. The cardiologist refers the patient to surgery, selects a revascularization strategy. So those two silos are not reality anymore. Now what we're looking at is this, is cardiology and cardiothoracic surgery working together, looking at risk-benefit ratio, assessment of access site, imaging of target site, treatment of complications, and post-operative care. So we are very big on pre-procedure planning, where in this patient specifically, we needed one axis for the pigtail to image where we're gonna go, and also to see exactly where we would put the valve. So we sometimes do what's called a three-dimensional reconstruction, and we have the three-dimensional that we can insert the valve inside to look at the annulus. So we very carefully looked at the annular size of this patient to make sure that the valve would fit here and would fit nicely, because it's acute AI. It's very important that in acute AI with patients like this, we need at least a 25% oversizing of the core valve into the annulus. So here you can see that we did the dimensions of the annulus. We have a perimeter of about 80 which sizes for 34 millimeter core valve. Importantly, the LVOT dimensions, the average is about the same as the annulus, which is a favorable anatomy to put the core valve in the right place. So here's the procedure in itself. The cannula, you see here the tandem heart cannula, and the core valve being deployed. We had long discussions with Dr. Simpson as well about what should we do in terms of what to do with the tandem heart. We have had some experience. I think it's probably number 3 or 4 patient that we do. And we actually decided to put the tandem heart on maximum heart flow along with pacing so that we could decrease the ejection of the ventricle. And we slowly deployed the core valve into this, to the annulus, into this big football. You see here that the patient's EF that was less than 20 actually recovered to about 35, 39. We had an excellent, and you can see here the core valve and an excellent seal of the core valve. We purposefully put this valve a little bit deeper, and this is the transthoracic, so that we could get a good grasp and not have any issues with a valve migration. This patient is now 6 to 8 months out of the procedure. I've seen her in clinic a couple of times. She's doing really well. We are actually, the EF is about 35, 39. We have discussed with her the need of maybe she should undergo another surgery to really fix the aneurysm now that she's in a better place. But this is kind of probably the spirit of this presentation today. This is our group that does the percutaneous stuff. We have NPs, mid-levels, we have administrators. This is Dr. Conero, Dr. Simpson. But this is what it looks like when we're doing cases. We alternate in the front, although Dr. Coselli is taller, so he kind of elbows me out of the way. And we have a very good team, a team that does quite a bit of good for patients. So Dr. Coselli.
Thank you, Dr. Silva, for your presentation. I think this case highlights the importance of the heart team approach for this type of complex cases. But we will connect you back to you shortly after Dr. Coselli's talk to have a round discussion about these cases. Next, it's an honor for me to introduce Dr. Joseph Coselli. Dr. Coselli is the vice chair of the Michael Lee DeBakey Department of Surgery, holds the Coleman Foundation Endowed Chair, and is the professor and chief of the Division of Cardiothoracic Surgery at Baylor College of Medicine. He serves as the chief of adult cardiac surgery at Texas Heart Institute. He's also an associate chief of the cardiovascular services at Baylor St. Luke's Medical Center, located in the Texas Medical Center in Houston. He's also the program director of thoracic surgery at Texas Heart Institute at Baylor College of Medicine, and directs the aortic fellowship program at Baylor College of Medicine. Dr. Coselli specialized in diseases of the aorta and was mentored by pioneering surgeons. Probably you recognize some of these names: Dr. Crawford, Dr. Cooley, and Dr. DeBakey. He has performed more than 10,000 aortic repairs and almost 4,000 repairs with thoracoabdominal aorta, for which is world renowned. He has published more than 580 manuscripts and delivered over 900 presentations in 30 different countries. So Dr. Coselli is also a 2-time recipient of the Michael Lee DeBakey Excellence in Research Award for his research on the surgical treatment of aortic aneurysms, aortic dissection, and Marfan syndrome. Welcome, Dr. Coselli, and we're looking forward for your talk.
Vicente, thank you. Guillermo, great presentation. Let me see if I can get my screen up. I hope you can see that. What I'm going to talk about is complex aortic surgery. I have a lot of material to cover in a relatively short period of time. So, but we're even with that, we're just going to be skimming the surface. There's no question that we have a lot of really less complex aortic problems that we deal with, infrarenal abdominal aortic aneurysms and simple descending thoracic aortic aneurysms, which in the past were open operations, but have moved almost exclusively to TEVAR and to EVAR. But what I'm going to try to address this evening or cover is going to be the more complex things, the aortic root surgery, transverse aortic arch, and thoracoabdominal aortic aneurysm surgery. In the Society of Thoracic Surgeons Adult Cardiac Database in 2017, and I don't think it's been much different in the last couple of years, over 14,000 thoracic aortic procedures have been performed. So this is something that's becoming more and more common. This is probably one of the more straightforward, but at the same time, one of the things that we see most often, and that's aortic root surgery, very common in patients with Marfan syndrome and similar connective tissue disorders, where the aortic root is, as Dr. Cooley used to refer to, as annulo-aortic ectasia, with and without aortic valvular insufficiency. And the treatment for that, by and large, has been replacement of the aortic valve, the aortic root, and the ascent in the aorta with so-called Bentall operation. So when do we operate on these patients? Well, the guidelines are if it's 5.5 centimeters in diameter, or if it's growing fast, more than 0.5 centimeter per year, or you have to replace the aortic valve based upon intrinsic aortic valve disease in the ascending aorta or root are greater than 4.5 centimeters. In connective tissue disorders, of which Marfan syndrome is the sine qua non, or the one that most people go by, if the internal diameter by transesophageal echo is greater than 4.2 centimeters, or the external diameter by CT scan or MRI scanning is 4.5 to 4.6 centimeters, or the ratio of the maximum cross-section area divided by the height is greater than 10. The last adjusts for a lot of these patients. Occasionally it'll be not very tall, so you have to adjust for this lack of height that you might have in patients with Marfan syndrome. So Hugh Bentall and De Bono in this case report in 1968 really combined what was becoming standard aortic valve replacement and supra valvular replacement with the ascending aorta, to combine the two with a single valve composite Dacron graft and replace the valve in the ascending aorta and reattach the coronary arteries. In today's world, we have a great number of opportunities and various tools in our chest for replacing the aortic root. Some of them are shown here in this slide. The standard Bentall, which is in the upper left, and then we have the porcine root. This is valve sparing, which we'll talk about in a minute. We use homograph replacements, particularly with aortic dissection. We can take a tissue valve or a mechanical valve, sew it to a Dacron graft, and have what we call a BioBentall. This is the Cabral modification of the Bentall, particularly useful in patients with redo surgery where the coronary artery origins are not very mobile. And then, of course, the Ross procedure, where we take the pulmonary autograft, move it over to the aortic position, and replace the pulmonary valve and pulmonary artery with a homograph. This is from the STS database. It's a little bit dated, but the point is that it shows that there's an increasing trend in aortic valve sparing, and particularly in BioBentalls, and we'll cover some of that a little bit more here in a second. Tyrone David really popularized the inclusion technique for aortic valve sparing, and we'll go through how that is done as we remove the ascending aorta, we remove the sinuses, we leave the actual leaflets and aortic valve mechanism in place and mobilize the coronary arteries. We not uncommonly will suture a graft onto the distal ascending aorta, but from the valve sparing standpoint, we'll place a number of sutures underneath the aortic valve apparatus, and then we'll take a Dacron graft and in effect pull the valve mechanism, the annulus and the leaflets, up inside the graft. You can see here, and then we reconstruct inside the Dacron graft in an inclusion technique, we reconstruct the anatomy, resuspending the aortic valve, and reconstruct the anatomy so that we've got a competent aortic valve inside a Dacron graft, and it's referred to as the inclusion technique. You can see that in this intraoperative photograph here. Here's an enlargement where you can see how the valve leaflets are suspended inside the Dacron, and then the coronary arteries here, the left coronary artery is reattached, and later the right coronary arteries are reattached, and then the two grafts are sutured together so that we've done a valve-sparing David inclusion technique. Another opportunity that we use when the valve leaflets are not sparable, but we want a tissue option that has a very good hemodynamic opportunity, and that's to use what's referred to as a freestyle tissue porcine root that's sutured to the aortic valve annulus, and then the coronary arteries are reattached as a button. Just very quickly, we a few years ago looked at 1,001 of our aortic root replacements, and composite valve grafts are so-called Bentel operations made up about 40%. Biobentals were used a little less commonly. We've done almost 300 now, but at this time we had done about 200 aortic valve sparing, as I just described. We had done over 300 of these bioroots, which I mentioned. And homografts are used primarily in patients with endocarditis, where we have to replace the entire root. The results are shown here with about a 30-day mortality rate of about 5%, stroke about 1%, renal failure 3%. So let's quickly look at aortic arch pathology. Aortic arch pathology very rarely is an isolated phenomena. It more often actually is associated with ascending and root pathology and or descending thoracic or thoracoabdominal pathology. Actual isolated arch pathology alone only makes up about 5 to 6% of such cases. So when do we replace the arch? When it's about 5.5 to 6 centimeters, or if it grows over 0.5 centimeter per year, or it's acutely dissected with extensive destruction of the aortic arch, where the tears in the arch itself and or acute dissection is superimposed upon a pre-existing aortic arch aneurysm. And again, we have a lot of options of techniques that we can use to replace it. There's the standard island technique of reattaching the visceral vessels. There's branched vessels, which can be taken off of the arch reconstruction to go to each one of the brachiocephalic vessels. We're going to talk about this a little bit more, where this is a single branch replacing the innominate, where the left common carotid and left subclavian are reattached. So island, as I've mentioned, but we've moved in many cases to these this so-called debranching technique, which has a lot of uses. And then there's the frozen elephant trunk with a collar, and we'll describe some of that here in a second. We used to use femoral artery cannulation in most of these cases to place them on cardiopulmonary bypass, but more often now we'll use axillary artery cannulation for aortic dissection. But if the opportunity arises, we use innominate artery cannulation. We used to use just simple deep hypothermic circulatory arrest. Then we moved to retrograde cerebral perfusion. But more often than not, we'll use bilateral antegrade cerebral perfusion. We used to use profound or very deep hypothermia, but we've moved to more moderate temperatures, which reduces the total cardiopulmonary bypass time by less cooling time and less warming time on cardiopulmonary bypass. And then particularly in patients with connective tissue disorder, in order to move the potential later pathology out away from the arch, rather than using an island technique, as we might in older patients with atherosclerotic disease and the connective tissue disorder, we'll use Y grafts or these branch grafts. And then in extensive disease, we'll use these collared elephant trunk grafts. And I might mention it allows us to have easier access with a more anterior anastomosis that's has an opportunity for less risk of nerve injury, and also is more accessible for for hemostasis. The simplest arch repair is an open distal anastomosis, or what we sometimes refer to as a hemiarch arch repair. I've already mentioned this Y graft with a collared elephant trunk, which is a more extensive arch repair. So we've got hemiarch, total arch, and then this consideration for at the first operation dealing with either very early necessity for replacing the descending thoracic or thoracoabdominal repair, or using an elephant trunk to prepare for a later operation beyond the arch to simplify and reduce the risk of that. So this is what this would look like diagrammatically. I've got this circle here in the middle of this elephant trunk, which can be used later for in this particular drawing showing an extent to thoracoabdominal repair, or it can be used as a landing zone to extend the operation endovascularly, particularly when we have a landing zone above the celiac axis and have a endovascular approach, which is done as shown here through the femoral artery. In acute aortic dissection in particular, although and occasionally when we've got isolated proximal descending thoracic, rather than using an elephant trunk, particularly in an older high-risk patient, what we'll do is simply do an antegrade deployment of a endovascular stent graft through the arch into the proximal descending, and then do a hemiarch to replace the remainder of the ascending aorta. In some patients who you simply don't want to use hypothermic circulatory arrest because they're high risk, you can use this debranching approach to the brachiocephalic vessels and then carry the endovascular stent graft into the distal portion of the ascending aorta, which we would refer to as a zone 0 landing zone, but it allows us actually to take care of the arch and proximal descending without placing the patient even on cardiopulmonary bypass, and particularly in high-risk situations. This is an intraoperative photograph and a 3D CT scan reconstruction of a patient as I just described. Here's another 3D reconstruction of what I just previously described. The other thing that I mentioned before is we'll use these collared elephant trunk grafts in order to establish an opportunity to treat not only the ascending aorta. Here in this diagram is an aortic valve sparing, ascending, debranching of the brachiocephalic vessels, and then a collared elephant trunk graft. And this is just a simple video where we've done the elephant trunk as I showed in the earlier drawing, and we're placing an endovascular stent graft in an antegrade fashion down into that descending thoracic component of the elephant trunk, put a little warm water in there to expand it, and then we'll carry out the reconstruction as necessary. We've had a clinical trial of a frozen elephant trunk device called the Thoraflex, where we're able to do all of this as a single piece, so that we've got a descending endovascular stent graft and then a Dacron opportunity to replace the arch and proximal ascending aorta. This is what this looks like, this particular device. This is just a simple, quick video showing where we've mobilized the brachiocephalic vessels. We'll take a wire from the femoral artery, place that through the Thoraflex device, and use that to guide down into the descending thoracic aorta. It has a simple mechanism where it unsheaths the endovascular portion, and then a plastic collar to release the collar that's used to suture to the distal arch. The latter part was also removing the device. Now, so you've got this picture showing the completion of the procedure. This is what this looks like in a patient with a drawing, where we come back later and place the endovascular stent grafts to complete the descending thoracic repair. You can see this on the arteriograms. This is a more complex aneurysm of the arch and proximal descending. We use basically the same techniques to replace the ascending arch and then stent grafting into the descending. In the arch, it's all about protecting the brain, which is only 2% of the total body weight, but it's metabolically, of course, extremely active, using a great deal of the total body oxygen and total body glucose. So protecting the brain is particularly important. That's why we use hypothermia to reduce the metabolic activity. It's only been recently that the ARCH project, they've developed a consensus for hypothermic classifications, which were very not very consistent in the literature. So now profound hypothermia is below 14 degrees, and mild hypothermia is above 28 degrees, and deep and moderate fall in between. This is just skimming the surface, but what temperature should we use? What cannulation sites are appropriate? And should we use simple deep hypothermia as we did in the past, or antegrade cerebral perfusion? This is a slide of some work that we did and published a few years ago, where we basically showed that at warmer temperatures here, above and below 20 degrees, but we use much warmer than that now. But when we used warmer temperatures, we had a reduced mortality, both 30-day in hospital, reduced stroke, and of course, less cardiopulmonary bypass time. This is one of the cardiac surgeons and a professor in our department, Arania Provenza, who looked at some of our data and published this in the Journal of Thoracic and Cardiovascular Surgery, did an excellent review of 665 patients with proximal in arch repair, and showed that the overall mortality was 5%, that at these warmer temperatures of over between 24 and 28 degrees centigrade had no significant impact on mortality, and it would be safe to use that at this level. This is a more extensive meta-analysis that showed that in these warmer temperatures, there was no difference in mortality, and actually the warmer temperatures had a reduced incidence or favored stroke and reduced renal failure on hemodialysis. So what about cannulation sites? Over the years, we've used femoral, axillary, innominate, left common carotid, direct aortic, subclavian, even transapical. All of these have been described. And this is from a European analysis of cannulation sites. And it's very interesting that even up to a few years ago, distal perfusion was still preferred, although there was a movement towards axillary artery cannulation, and then, of course, bilateral antegrade perfusion. Axillary artery, the rationale is it simplifies the delivery of antegrade cerebral perfusion because you can clamp the innominate artery and perfuse the right common carotid artery. It thus helps to avoid malperfusion that femoral artery perfusion is sometimes plagued with. It's particularly useful in aortic dissection and also in reduced sternotomy, so that it gives you access for going on cardiopulmonary bypass prior to sternotomy. The last number of years, we've moved to, whenever possible, just directly cannulating the innominate artery, and our preferred approach has been to sew a graft on there, although you can use a plastic cannula if so needed. This is another very nice review from a few years ago that a professor of surgery in our department, Arania Provenza, published in the Journal of Thoracic and Cardiovascular Surgery, basically showing that in the innominate artery cannulation in 68 patients, it was very effective and had very acceptable in-hospital mortality rates, permanent dialysis, renal failure, and stroke rates. This is a retrospective study from the Japanese nationwide database where they compared antegrade cerebral perfusion with retrograde cerebral perfusion and straightforward deep hypothermic circulatory arrest, showing that although retrograde cerebral perfusion required a longer cardiac ischemic time, there was no difference in mortality or stroke rate between these. This is from the Cleveland Clinic that looked at retrograde versus antegrade cerebral perfusion and showed there was no difference with regards to mortality, neurological events, and stroke, although the study was probably underpowered somewhat. This is a more extensive comparison between antegrade perfusion, retrograde perfusion, and deep hypothermic circulatory arrest. from a very recent publication in the journal last year. And it showed that compared to straightforward deep hypothermia, antegrade and retrograde were favored with their potential to provide nutrition directly to the brain. This looks at 2,220 of our open arch repairs where our mortality rate was 7% of all comers. The stroke rate was 3%, renal failure was 5%, and paraplegia was very, very rare. And this includes a group of patients which 17% were not elective. They were emergent or urgent, and reduced sternotomy made up 10% of the cases, which included 70. So let's talk about thoracoabdominal aortic aneurysms here real quickly. What we want is an anatomic reconstruction, and this is what some of this looks like. The things that are at risk are the spinal cord, the kidneys, as well as the visceral organs. This is a very interesting stone carving from Babylon showing the problem of paraplegia. Here, a lion shot with arrows transgressing the spinal cord and creating paraplegia. One of the things that's been very valuable in reducing this has been CSF drainage, which we've used extensively over the years. In the Cochrane review, we participated in the 3 most important randomized studies on CSF drainage. And the most recent one, which really sort of made CSF drainage so important in particularly extent 1 and extent 2 thoracoabdominal aneurysms, reducing the incidence of paraplegia. We looked at 156 patients, which were in the extent 1 and extent 2 variety of thoracoabdominal repair, and showed that the incidence of paraplegia with CSF drainage was statistically significantly reduced from 13% down to 2.6%. Left heart bypass, where we perfuse distally while we're working on the proximal aorta. We've not done prospective randomized trials, but we have a lot of retrospective data to go on. We used to cannulate the left atrial appendage. We cannulate the inferior pulmonary vein now. We used to cannulate the femoral artery, but more often now we'll cannulate the descending thoracic aorta. We looked at 330 extent 2 thoracoabdominal aortic aneurysms a number of years ago, and we're able to show that left heart bypass, when we used it, statistically significantly reduced the incidence of paraplegia. In the extent 1 thoracoabdominals and the descending thoracic aortic aneurysms, it didn't have quite the statistically significant effect. This is what this looks like in the operation, cannulating the left atrium via the inferior pulmonary vein, draining into a centrifugal pump. And we use CT scanning and MRI scanning to try to find, and sometimes peri-aortic ultrasound to find an area to cannulate the descending thoracic aorta, usually above the celiac axis, in an area that won't cause dislodgement of thrombus. I wasn't going to talk much about dissection. It's really almost a topic all by itself, but this is an example where we cross-clamp the aorta with dissections for thoracoabdominals, usually proximal to the left subclavian. We transect the aorta distal to the left subclavian artery. We clamp the aorta in the mid-descending, perfuse distally, select a graft an appropriate size and length, and then suture it to the aorta distal to the left subclavian artery, transecting the aorta there to separate it from the esophagus. On the right-hand side, showing how we suture these into elephant trunks, and then move the cross clamp down to reestablish perfusion to the left subclavian artery, because the left subclavian artery through the vertebral artery and the circulation through the circle of Willis and down into the anterior cerebral artery is important in reducing the incidence of paraplegia. So then we'll take the clamp off, we'll open up the thoracoabdominal aneurysm, we'll put perfusion catheters off of the left heart bypass oxygenated blood into the celiac and the supramesenteric artery, cool the kidneys down with separate perfusion cannulas, and in the little video on the right, we began to reattach intercostal arteries, usually as an open patch. We found that reattaching intercostal arteries is when we looked at 1,114 extent 2 open thoracoabdominal aortic repairs, and we looked at what reduced the incidence of paraplegia in addition to CSF drainage. Reattaching intercostal and lumbar arteries reduced the risk, and specifically in patients who had heritable disease. We've done 2 randomized clinical trials cooling the kidneys down, and we've shown that reduces the incidence of postoperative renal failure. And so this just shows on the right-hand side, putting perfusion cannulas off the left heart bypass into the celiac and the supramesenteric artery, and then perfusion cannulas into the kidneys to cool them down. This is what this looks like intraoperatively. So we'll move the cross clamp down, restore flow to the intercostal arteries, and begin a distal anastomosis. And that allows us with these branch grafts to open the flow into the iliac arteries, which again, through the internal iliac arteries, helps perfuse the spinal cord and reduces the incidence of paraplegia. The next step is to reattach the branch graft to the right renal artery, then to the SMA, then to the celiac, and then to the left renal artery. And we end up with this kind of reconstruction. What this looks like in this very, very quick little video where we've opened up and removed the wall between the true and the false lumen, in effect to create a single lumen by removing the septum between the two. This is perfusion cannula into the celiac axis, then into the supramesenteric artery. Cooling catheters first into the left renal artery and then now into the right renal artery. I've done the proximal anastomosis, then we'll reattach to an opening in the side of the graft the intercostal arteries. Just done with simple running Prolene sutures. Then move the cross clamp down to perfuse the intercostal arteries and hopefully the spinal cord. Cut the graft to length and do it here in anastomosis right at the aortic bifurcation. And we'll take the clamp off. Now we're perfusing the legs. And then as I described in the drawings that I showed you a minute ago, using these branch grafts to reattach the visceral arteries. Done the right renal artery, then this is the supramesenteric artery and the celiac axis. And I think you get the idea. I had the opportunity to present 3,309 cases a few years ago to the American Association Thoracic Surgeons, and this was published in 2016 in the Journal of Thoracic Cardiovascular Surgery. 1,066 were the extent 2 thoracoabdominal aneurysms. Here's the breakdown. Actually, age 80 or greater made up almost 200 patients. We don't operate upon acute dissection unless it's on a superimposed aneurysm that's already dilated, but you can see here dissection made up a great many of these patients, and 288 had Marfan syndrome. You can see this breakdown in DeBakey type 1 versus DeBakey type 3 dissection with an almost 50-50 split in the extent 2 aneurysms. This is previous cerebral vascular disease was not uncommon. Previous chronic renal insufficiency was not particularly common, but was almost 100 patients. This is a little bit dated, but at this point in time, when we did these aneurysms, we extracted 29 TVARs, carried out 80 reverse elephant trunks, and completed 133 elephant trunks. You can see here that intercostal artery reattachments extremely common, but almost ubiquitous in the extent 2 aneurysms. This shows the use of left heart bypass and selective perfusion of the celiac and the SMA, which left heart bypass in the extent 1s and the extent 2s was very common. And then selective perfusion of the celiac and SMA in the extent 2 aneurysms was extremely common. For cold renal perfusion, basically anytime we have the renal arteries accessible, we try to do cold perfusion. We had permanent paraplegia in almost 3% of the patients and an operative mortality rate of under 8%. Interestingly, in this series of my experience, we'll sometimes have very, very many patients without paraplegia, but then we'll do an emergency operation, et cetera, and paraplegia will strike back. The operation's very durable. You can see out to 15 years, there was actual failure of the operation in only about 15 to 16% of patients. A more recent look at 3,654 thoracoabdominal aneurysms. The 30-day mortality rate was 5, where the operative mortality rate was 8%. Paraplegia, persistent paraplegia stayed at about 3%. Things have changed. This is Michael Dakes, his first report of using endovascular covered stent in the descending thoracic aorta. I'm not going to belabor this a great deal, but this has exploded. And in addition to some of the endovascular work I mentioned before, most of our experience with thoracoabdominal repair has been back table modification of the Cook device. So one quick example, this is a patient who had a endovascular stent graft with connective tissue disorders and emergency in the descending thoracic aorta elsewhere, and came to us with an enlarging symptomatic aneurysm of the descending thoracic aorta. We just simply removed the device and replaced all of the descending thoracic aorta. This patient returned later with a type A dissection, which involved the aortic root and the arch of the aorta, which we replaced with a Bentel operation for the aortic root, debranched the brachiocephalic vessels, and then joined the two grafts of the distal ascending aorta as a zone 0 repair, and then extending across the arch with an endovascular stent graft to simplify the operation. Patient came back with an expanding thoracoabdominal aortic aneurysm, which we came in and did a final repair, as you can see here in this drawing, in this post-operative 3D reconstruction where we replaced the thoracoabdominal aorta. The past has been interesting. We've learned a lot. We have a lot of tools in our armamentarium presently, and the future is going to no doubt be very, very interesting with even more endovascular reconstructions. As Dr. Guillermo pointed out, Dr. Silva talked about the heart team. There's no question that the cardiothoracic surgeons, interventional cardiologists, much work together with our interventional radiologists, vascular surgeons, as well as I point out the nurses working in the operating room and the post-operative care, and the critical care specialists who help manage these patients post-operatively. This is no doubt, this is not a individual surgeon. This is a team which is critical of everyone working together in the best interest of the patients to have the best possible results. I know I've gone over a little bit, even though I was very superficial in a lot of my discussion. Thank you very, very much for your attention.
Thank you so much, Dr. Coselli. This is a great presentation of all the spectrum of pathology that we treat here and at Baylor St. Luke's. But I just want to remind the audience to please send your questions either in English or in Spanish, and I will pass this question to the speakers. Alex, I don't know if we have any questions right now, but I would like to start with a question for Dr. Silva. Dr. Silva, this case that you presented, certainly it was a high complex case and for aortic valve regurgitation. So in this stage on age, in TAVR for aortic valve regurgitation, where are we in the United States?
Well, I think that's a very good question, Vicente. The state of TAVR nowadays is that we can do aortic regurgitation. We do need to have, to be mindful of a few things. One of them is the presence of calcium in the annulus. If we don't have calcium in the annulus, we do need to oversize the TAVR valve at least 25%, 20 to 25%, so that we don't have an embolization of the valve. This case specifically that I presented is quite challenging, and whenever somebody like Joe Coselli that has done, I don't know, thousands of this says, oh, this patient will be better off with a with a TAVR, you need to sit down and respect and look very carefully to give them a TAVR. One of the things that I learned from Joe has been, has changed my practice, and you can see this over and over and over in his presentation, is that you do what's essential for the patient to survive, to get him out of the operating room, out of the hospital, and then you bring him back and fix the rest. So one of the things when I started, whatever, 2008 in the United States, it's like I wanted to fix everything. It's like, okay, let's just get everything. And sometimes you give a little bit more contrast, or the patient is hypotensive for a little longer, and then the kidneys go, the liver goes. So I'd like to have Joe kind of elaborate a little bit on the strategy, on how he came to this conclusion in this very, very hard patient population, that's the aorta in general.
Yeah, no, Jeremy, I agree entirely. How did we come to it? Through a lot of bad experience, both with working with our mentors, and then I've personally kind of been at this a long time, and we learned a long time ago not to be too. Well, Dr. Crawford used to say, "Let's don't be too greedy. Let's just fix what's going to kill them today, and we can take the care of the rest of it tomorrow. But if they don't make it today, tomorrow, doesn't exist for these patients." And I think this is particularly valuable, although I hadn't had a chance to really elaborate much on aortic dissection. It's patients with frequently the aortic dissection have extensive pathology of most or all of their aorta, but from an aortic standpoint, only one part of their aorta is actually doing them in at that particular time. They're descending, their abdominal aorta, their proximal aorta, et cetera. Fix that, and then we can manage the rest of the aorta at another time. The example that you showed, I think, is a perfect ramification of that. That's a patient who would have been very hard to get through an aortic operation where you have to deal with the valve, the root, and the arch. It's doable. Doing the surgery is doable, but the goal is not to just do the operation. The goal is to have the patient recover and enjoy life. And so in this example, the thing that was really affecting that patient was the aortic valve. So let's take care of the aortic valve, and then get the heart recovered, get the patient recovered. Get us out of a situation where we're dealing with multiple organ failure, and then we can deal with the rest in due time, because we've got a live patient to work with.
Yeah.
And usually a very grateful patient, by the way. Thank goodness.
Absolutely.
Great points. The next question is, it will be for Dr. Coselli. So you have a patient who got a valve sparing root operation and younger age, and he has 10 years after, and now he needs a reoperation because of aortic valve regurgitation. This patient can have a TAVR.
Yeah, that's a good question. A couple of things. One, there obviously there's some valves you just simply can't spare. Then there's some valves that fall into a gray area, and I might mention that in my own practice, I've favored pretty much the David 1 inclusion technique as opposed to the Yakub operation. We don't have time to go into all the details of these, but there are patients whose valves, the leaflets are sparable, but judgment says that they probably shouldn't be spared. Tyrone talks about even though they're not in the coaptation, even though the fenestrations are in the coaptation surface, for instance, but if you've got large fenestrations in all three leaflets, you can make that valve competent. You can spare it, but in a very short period of time, you're not going to have a functional valve. So the good thing is that in many patients, particularly connective tissue disorder, who have root aneurysms and have viable leaflets, we can spare these valves and do these inclusion techniques. And then down the line, 5 years, 10 years, 15 years, the Dacron graft, which goes down below the actual native annulus and is at the very distal portion of the left ventricular outflow tract, does make a good substrate and a good landing zone for a later TAVR. We haven't done very many of those, but we have done them, and it does work. So it's an opportunity for these patients to have a very extended portion of their life without having to take Coumadin, but also have, a valve sparing inclusion technique from a hemodynamic standpoint is a very, very good operation. It is a mismatch, prosthetic patient mismatch almost doesn't exist in that operation. And by and large, these are larger roots so that they're, 28, 30, 32. And so you can put a very large TAVR in there, again, with a very excellent hemodynamic situation, unlike you have when you're worried about aortic valve. And again, they have aortic valvular insufficiency most of the time, but there's still a very excellent situation to do a TAVR and have a good hemodynamic result.
The next question it will be for Dr. Silva. So, Dr. Silva, how you counsel a patient, a young patient comes to your clinic, and he's a low-risk patient, has a bicuspid valve, and he wanted to have a TAVR. What patient you say, listen, you're not qualified for a TAVR, or you should go for a minimal invasive surgery? How you can how do you decide? How you tell the patients?
Well, that's a very good question. I think that question has to be answered differently. The first question I ask the patient is, I think that mechanical valve it still has its role, especially in the young patient. If you have somebody that's under 65, especially under 60, you will be better off with a mechanical valve. I'll tell you that, and that's the current knowledge that we have. Of course, with the durability that we have of the TAVR valves, we don't know yet, but we know that up until 8 years, bioprosthetic valve, TAVR valve will probably sustain the patient very well. But so what I tell the patients is, look, you want to be one and done and have a mechanical valve, or we will be, seeing each other every, 8 to 10 years. And then you have to be very, very careful and looking at the anatomy. And of course, this is a very controversial issue that all of us have been facing. But in general, I tend to favor putting the biggest valve that give the best hemodynamic result for the patient, and which opens up what is the next step. So you need to think about what's the next step. If the coronaries are low, if the STJ is narrow, then if you put a TAVR valve, you're gonna, kind of jail this patient into another, probably into a second operation. If you have somebody that you can put a big SAVR that will then be a TAVR and SAVR, and then a TAVR and SAVR, then this might be the best thing for the patient. And so I tend to kind of look at the patient, get a good, CT TAVR protocol, and then you can kind of make a good judgment. And not only you, myself as an interventional cardiologist, but also, get the imaging guy on board, get you guys from surgery, so that we can make that decision together. But one of the things that I would like to kind of highlight is the amount of complexity of those patients with aortic valve disease, and the number of nuances and that you can, especially when you talk about the thoracoabdominal aneurysms. So it's very important for the cardiologist and even the cardiac surgeon that's hearing this live event to realize that there's a lot that can be done for those patients, and that sometimes those patients, and probably most of those patients, would benefit from a trip here to get somebody like you, Vicente, and Dr. Coselli, that have had so much extensive experience that you can probably give a different approach, a fresh approach, something that will not be able to be done by somebody that hasn't done, 4, 10, whatever, thousand operations in this kind of population.
All right, thank you for Dr. Silva. So moving on to the next topics, we have a couple questions. It's for Dr. Coselli. Dr. Coselli, we know that the Thoraflex is FDA approved in the United States, but what is not currently available on the shelf in different institutions?
We have the United States kind of lags behind many other countries. In fact, most other countries, when it comes to devices, the FDA is very, very protective. For instance, right now, what we don't have is we don't have any of the frozen elephant trunk devices. The two significant ones worldwide are the Thoraflex device, which we've done a clinical trial on here in the United States, and it sits with the FDA right now, and hopefully it's going to be approved for use. There's been some snags with regards to some of the material engineering that the FDA has actually held it up, but the clinical trial has been completed. It was very successful. It shows the device is very effective and quite useful. And hopefully that'll be available soon. The other one's the Avita device, which has extensive use in Europe as well as around the world. And it's my understanding that hopefully that also will have clinical trial here in the U.S. and be available soon. There are no endovascular devices that are approved by the FDA for thoracoabdominal use right now, but there's a number of devices that are in clinical trials. The TAMBI device would be an example from Gore. The Cook has also has a thoracoabdominal graft that's under evaluation. There's many physician IDEs and institutional IDEs that as well as back table modifications. So there's a lot of endovascular work being done in the U.S. On the thoracoabdominal aorta, very, very successfully, I might add. But there's just no FDA off the shelf. You can use it as you can other devices like we have EVAR and TVAR.
All right, thank you. I think we have time for one more question, and the next is regarding the thoracoabdominal aortic aneurysms. So you open the aorta and you suddenly find out that the ostium of the vessels are very calcified and possibly need something to open these vessels. How do you deal with these problems?
Well, let's break them down into three different kinds of patients. There's the patients with hereditary disease, the Marfan patients, Loeys-Dietz, et cetera. They very rarely, because they're at a young age, have superimposed atherosclerosis. Interestingly, most patients with aortic dissection as a group compared to fusiform aneurysms are about 10 years younger. And again, it's not quite so common to have superimposed atherosclerosis. In the fusiform aneurysms, it's extremely common to have stenosis of one or more of the visceral vessels. My preference to the right renal artery, because it's inaccessible in its distal extent, is usually to put an endovascular stent antegrade directly into the orifice. And in the celiac SMA and left renal artery, it's a combination of endarterectomy and antegrade direct vision stent grafts in combination with the branch grafts that I mentioned earlier.
Right. So before we close the discussion, any last minute words before we go, Dr. Silva, Dr. Coselli, for the audience?
I would just like to thank everybody who might be listening to this. We really appreciate the opportunity to share some of our thoughts on aortic pathology and valvular pathology with you. I think a takeaway message for surgeons and cardiologists would be a couple of things. One is Dr. Silva mentioned, and I think it's so critical that it's a team approach rather than having a single individual to have multiple eyes and multiple brains look at a situation and consider all the various possibilities. I think institutionally, it's very, very important to have a lot of different possible potential techniques and approaches in your armamentarium. Don't be we shouldn't be as individual physicians narrow-minded in the way we approach something. As the old saying goes, if you're a hammer, everything looks like a nail. But to be open-minded both into various possible techniques into solving the problems that face us today, but also be open-minded as to what the future is going to offer us with new technologies, new devices, new opportunities for imaging, and to solve old problems with new and very innovative techniques.
Okay, thank you, Dr. Coselli and Dr. Silva, for your time tonight, and thank you everybody who connect tonight as well. Before we finish, Baylor St. Luke's would like to recognize and acknowledge the following entities for their support and partnerships in today's program. We want to say thank you to the Universidad de San Francisco de Quito, Sociedad Ecuatoriana de Aterosclerosis y Endotelio, la Sociedad Mexicana de Cirugía Cardíaca, la Sociedad Mexicana de Cardiología, la Asociación Nacional de Cardiólogos de México, la Sociedad Peruana de Cardiología, la Sociedad Peruana de Cirugía Cardíaca, Torácica y Vascular, the Gulf Interventional Society in Emirates, and Saudi Heart Association, the Emirates Cardiac Society, the Emirates Medical Association, Top-to-Toe Transcatheter Solution, and Hamad Medical Corporation. Also, I would like to remind that Baylor St. Luke's will invite you to our next international virtual roundtable on the February 25 at 6 p.m. With one of our faculty, Dr. Taylor Ripley. He's the director of the Mesothelioma Treatment Center who will present on this topic. Also, we would also like to invite to join Dr. Coselli and Dr. Silva and other members of our Baylor St. Luke's team at the Gulf Intervention Society meeting this coming Friday at 7 a.m. For a case presentation. The topic is going to be complex structural heart disease from TAVR to mitral clip. And also, I would like to remind our audience that the session is being recorded and remains available in the YouTube channel. And thank you so much for your time. And it was a pleasure to spend time with this distinguished panel. Thank you and have a good night.